Why did that really just happen? Uh-huh.
Is the slow chest, is that the what's it called? No, it's the impulsion.
Yep.
All right, guys. So Miss Taylor is going to be doing your lecture today on end of life. She is a very good person to do that with you guys because of her experience in hospice care. And I know that she had you do some pre-work prior to coming in, so she's going to have you do like some interactive type things. I am recording this. If you guys notice, apparently I maxed out Canvas on what I could upload. Like, how does that even happen? So I was all like, no, I'm not doing a YouTube channel. And now I'm like, I guess I have to do a YouTube channel if they want to watch these. So I put them, do what? What'd you say? Yeah.
What's my YouTube channel?
Oh, listen, you should hear my kids. They're like, what's up, guys? It's Haley and Jace. Welcome back to our channel. I'm like, I can't remember this stuff. And they send it to their friends. They're like, watch my vlog. And I'm like, you're 5 and 7.
I love that.
I can't even with this right now. And I'm over here, like, I hate my voice. Why do I have to record? But it is going to be recorded, so you guys can refer back to it. I'll download it and put it on my channel, so you guys can watch it.
You'll start vlogging now.
Oh, yeah. I'll be like, this is so awesome. I'm like, University students. So, I'll be doing that. But please give Miss Taylor your attention. I know you guys will, and feel free to interact as well. Did you bring me cards? Did you bring cards? Okay. Okay.
Okay, so did everyone bring their pre-work, their cards with the activities, food, and people? Okay. So what I'm going to do is I'm going to pass out a card with a number on the back. And I want you to keep it face down for now. And wherever you want to put it, so that it's not in your way.
In theory, if someone forgot to do it, that they did the discussion board, is that okay? Or do they need to do it really quick?
Yeah, go ahead and just tear up a piece of paper into 6 pieces. Write down 2 of your favorite activities to do, 2 of your favorite foods, and 2 people who are very important to your life. I can take.
I don't know. I don't know. Yeah. Very.
For me. Is the thought sound a person? I think it has to be a person like, is it a person, like physical? Miss Taylor, does it have to be like a physical person, or can it be like your father?
Yeah, a physical person, like a mom or a significant other. And you can also put, if you have, I don't know if anyone in here has kids, you can put just your kids. You don't have to
You don't have to pick the kids.
pick.
I don't have it.
Pick between your children.
You have to pick your favorite child.
Can't find my clicker. Oh, well,
What's the difference between palliative care and hospice?
we're gonna go over that because it's really confusing. Is everyone done with their cards? Okay. So I minored in psychology when I was getting my BSN. For a hot minute, I ended up not completing that, but I learned that stress and anxiety are not conducive to learning, teaching, pretty much anything. I understand, y'all had a test this morning, right? Same thing with my first lecture. Okay, so if everyone will please stand up. We're gonna get centered for a minute. So I want you to put, that's kind of like you're doing the Pledge of Allegiance, and then one on your belly. We're gonna focus on our breathing. I want you to take a deep breath in and to make your hand on your chest rise up. And then blow it out. Good. Now I want you to make the hand on your belly come up. And I want you to keep doing that, alternating between the chest and the belly. We're going to breathe in peacefulness and blow out stress. We're going to breathe in calm and blow out anxiety. We're just going to focus on the things we can control, which is learning. And we're going to thank God for the opportunity to come together and to learn and to better ourselves. Amen. All right. End of life care. Yeah, it's a hard sell. I know that. You may be wondering what I did to make Dr. Edmondson so mad to give me this topic, but I actually chose it because it's a very, very important field in nursing, and it's often looked over because it is hard. It's emotional, both for the patient and family and the nurses. I looked at your all's discussion boards, and I really enjoyed reading your responses because it tells me how far we've come to educate nursing students and the general population to not view hospice in such a negative way. You know, several years ago, there were a lot of negative emotions related to hospice. Oh, the patient gave up. They're just ready to die. Depression, you know, all these horrible things. And so reading your discussion boards, it was really encouraging that a lot of you saw it as peaceful and comforting. And that is good. So the outcomes for this presentation are going to be that by the end, you're going to be able to list the signs and symptoms of end of life, state the difference between palliative care and hospice, describe how to promote comfort for a dying patient, interpret the different legal and ethical obligations of end-of-life nursing care, and value the importance of collaborating with members of an interprofessional team while caring for the dying. Now, I personally think it's important to know who is teaching you and why they're qualified. So I'm going to tell you a little bit about my background. I graduated from ETSU with my BSN, and I started my nursing career at Bristol Regional Medical Center. That's where I met Dr. Edmondson. I worked ER and trauma, and I also worked med-surg oncology palliative care. So I have a little bit of background in end-of-life care even before I left the hospital. And I took care of a wide range of patients, and several of those patients also belonged to my primary care physician, Dr. Shrinker. Now, Dr. Shrinker, I don't know if any of y'all know him, he is a hoot. He has been my doctor since I was 16 years old, with the exception of when I lived in Louisiana for 6 years. So we've had a very good relationship. Any of my visits, we would talk about the politics of healthcare, how to provide good patient care. Well, apparently one of the patients that I took care of in the hospital, was one of them that liked me, yay, saw me in the waiting room of Dr. Shrinker's and apparently sung my praises. So a week later, I get a call from Caris Home Hospice, and it's the director saying that their medical director, Dr. Shrinker, had told them to hire me. Now, quick side note, I went into nursing to be an OB nurse. I wanted to help deliver the happy little babies. So that's over here. And then hospice. death. Kind of two ends of the spectrum, right? Black and white. Could not be further apart. Honestly, never even considered hospice. So they asked me, can you at least come in for an interview? I knew I didn't have a lot of interest in going into it, but when a doctor does something like that, you at least show up for the interview. And I said, okay, I'll just hear what they have to say. So I go into the interview, and it's the director and the patient care manager. And the first thing that they ask me is, why are you interested in hospice? That's an oh crap moment, because my mom always taught me, if you can't say anything nice, don't say anything at all. But that's not an option in an interview, right? But I had no interest in hospice, so I had to really think on my feet. I do not recommend this tactic if you actually want the job. Although apparently it worked, because I said, well, why don't you tell me why I should be interested in hospice? They said, well, we have an interdisciplinary team that supports these patients and families. And I'll go into the interdisciplinary team later. And everybody is born and everybody dies. Do you want a good death or a bad death? Well, that took me back for a minute, because I was like, I want a good death. I want all the meds, okay? All of them. I don't want to feel a thing. So it got me to thinking. And when I left the interview, I actually was entertaining the idea of doing it. One thing was standing in my way. Can we talk about this uniform for a second? This is nobody's color, okay? The picture does not do it justice. I did not have to worry about getting hit by cars at night. It was that bright. So maybe I was vain, but I was like, I don't know. But they called and made an offer, and I prayed on it. And I thought, you know what? Let's step out of our comfort zone and let's give this a shot. I can always go back to the hospital if it doesn't work out. As you can imagine, it was a total 180. You know, they talk about culture shock. Like when I moved to Louisiana, there was a culture shock because it's not like Northeast Tennessee. Well, when I moved to hospice, hospice is different from any other field of medicine. Why? When your specialties in nursing, what is your primary goal? Yes, keep them alive. Try to restore them to their optimal level of health, right? What's your goal with hospice? For your patient to die comfortably. So it's a total 180, and it affects every aspect of care. Because when you spend half of a decade with the mindset, I'm going to get my patient better. We're going to do this. We're going to help them to live the best they can. To, I'm going to help my patient die. Total 180. So now we're going to move on to the interactive activity. Everybody with a number 1 card, please flip it over. Your family has noticed you have been forgetful lately and have trouble finding your words. They take you into the doctor to be evaluated. I'm very sorry, but you have dementia. Everyone with a number 2 card, please flip it over. You quit smoking after several years. You're proud of yourself, your family's proud of you, but you notice that you've had increased shortness of breath lately, and you've actually had a couple episodes of coughing up blood. So you go to the doctor to be evaluated, and I'm very sorry, but you have stage 4 lung cancer. Changing perceptions of death. That can be very difficult. This lady is named Cicely Saunders, and she is the founder of Modern Day Hospice. What she did was to help change the perceptions of hospice. A lot of common views up until recently are that hospice is sad. It's the end. It can be painful, it's scary, it's a loss, it's unnatural. But she and the hospice nurses that followed her have been working diligently to change those perspectives so it can be peaceful. It can be a new beginning. It can be comfortable. And they help the family and the patient to know what to expect. And that helps alleviate that fear and the scariness. As a hospice nurse, you are going to lead the families to understand and gain knowledge and joy that their loved one is going to be at peace, that they're no longer going to suffer. And you can help them understand that it's a natural process. There are two quotes that I found that really illustrate what end-of-life care can do. Now, I don't feel like being old today, so I'm just going to tell anyone that may not know that Helen Keller was a remarkable woman who happened to be both blind and deaf. And this is what she had to say. Death is no more than passing from one room into another. But there's a difference for me, you know, because in that other room, I shall be able to see. That is one concept as a hospice nurse that you really need to cling to because it helps you to tend to your patients and their families. Because you know that once they shed that earthly body, they are going to be free from disease and pain and limitations. The second quote is by David Searles, and he says, "Seeing death as the end of life is like seeing the horizon as the end of the ocean." All right, interactive activity time again. My dementia patients. You have become more confused and can no longer be left unsupervised outside the home. Please select your activity card that requires the most cognition. Read it to yourself quietly, and then discard it by your desk because you can no longer do it. My lung cancer patients. You're having increased shortness of breath, and now you have to wear O2 at 2 liters per minute nasal cannula with any activity. Please select the activity card that requires the most physical ability, read it to yourself, and then discard it by your desk because you can no longer do it. Birth, death, and taxes. They are all inevitable. So when we're looking at death, we really only have two options. We can have a bad death without dignity, with suffering. It can be painful, and we can have no control. Or we can have a peaceful or good death, where we die with dignity, we have some control, and it's without suffering and pain. I would be very surprised if any of you raised your hands and said you wanted the first option for you or one of your loved ones. We all want option number 2 for ourselves and for the people that we love. Advanced directives, what are they? Why do you need them? It's a document of self-determination. So you want to be filling these out, and hopefully your patients have filled them out prior to needing them. One example is a living will. I am currently working on my living will. I really should have done it before now. And I'm going to use this as long as I can. I'm still in my 30s, so I didn't think about it. But as Dr. Edmondson can tell you, we have seen babies die. We have seen elderly die, and we've seen everything in between. It can be depressing to think about these things, but just keep in mind you need to do them. So the living will basically spells out what you want done in certain circumstances. Luckily, my attorney is my cousin, because I would have felt a lot more judgment if it had been a stranger. He knows I was an ER nurse. I have a very detailed living will. I have said, I'll be a paraplegic, I'm fine with that, but I will not be a quad. You remember the story that Dr. Edmondson was telling you about her burn patient with burns over 90% of his body and his back was slopping off. No, thank you. God bless him, not for me. So I have a very detailed list. Another advanced directive, and I forgot to put this on there, so you can jot it down real quick, I'm very sorry, is a DNR, a do not resuscitate. You will see this a lot with patients that have embraced their terminal diagnosis of maybe cancer, COPD, whatever the case may be. Another one is your durable medical power of attorney. And it basically appoints a person of your choosing to be your healthcare proxy in the event of an issue that's not covered under the other advanced directives or in the event that you do not have one. So I'll give you an example. My oldest son, Alex, is my power of attorney. If there is a situation, and it would have to be really weird and crazy, but if there was a scenario that was not on my living will, the doctor would go to him and say, this is not covered under your mom's living will. What do you think she would want done? And then he would have to make that decision. But let's say I didn't have a living will or a DNR or anything, then the doctors would go to my son Alex and say, what do you think she would want done? Because they don't have anything to go off of. Now, if you don't have a durable medical power of attorney, then it defaults to your next of kin. Some of us may have to think a little bit harder than others if that's a good idea and how soon we need to get one. These are important because keep in mind, if you don't have these in place or you haven't had these tough conversations with your next of kin, you could wake up in a way that you don't want to wake up in. So I try to look at it like this. I'm going to take joy in knowing that I'm not going to wake up in a way that I don't want to. I'm getting it done, and once it's done, I'm just not going to think about it. I'm just going to know I'm prepared. All right. My dementia patients. You are too confused to function effectively by yourself, even at home. You are forgetting to eat and having difficulty with toileting hygiene. Please give up your remaining activity card and one of your food cards. My lung cancer patients. Your pain and dyspnea have increased. Pain medication has been increased, and your O2 is now continuous. Please give up your remaining activity card and one of your food cards. Because you also are experiencing depression because you feel like you should have quit sooner. And maybe if you had to quit sooner, you and your family wouldn't be going through this. 2 seconds. Okay. There is a concept that's very hard even for other nurses to understand. So we're going to approach this using a cancer patient as an example. So with curative treatment models, that patient's ready to fight. Okay, they want to beat it. They're in it to win it. They want chemo, radiation, and surgery. That is the curative treatment model. Hospice, for whatever reason, maybe their prognosis is poor, but maybe they're just tired because fighting cancer is rough. And I have had patients that have just opted that they don't want to do that. They want to be kept comfortable and live out the last of their days as best they can. And that is the hospice treatment model. So palliative care. Palliative care is tricky because it's neither curative nor hospice. It's somewhere in the middle. It can also be a standalone treatment model. This would be a patient who maybe their cancer has reoccurred. They have a mass in their brain that's pressing on it and causing headaches. So they want palliative radiation to shrink it down to help with the symptoms while they try to decide if they want to go curative or hospice. So we're relieving the symptoms to give them time to think. Also, you can actually use it with hospice. That is a big misconception. Because again, is palliative a curative treatment? No, it's a symptom management treatment. I have had a couple of patients that we did actually do palliative radiation on because we couldn't get good symptom control with medication alone. So that's an example of using it with hospice. Another example would be tube feeding. Now, you may have heard that no patients on hospice can be on tube feeding. That's halfway correct. You would never initiate tube feeding on hospice because that prolongs the patient's life. Your job as a hospice nurse is not to help your patient die faster or slower. You're just there for the journey. But let's say you have a patient with esophageal cancer that can't swallow their meds and can't eat, and the doctor says they should have 5 to 6 months. What's going to happen if hospice says no tube feeding? They're going to have no nutrition, no meds. What's going to happen? Are they going to die faster? Yes, and that's not what we do. So we do have patients on tube feedings in special circumstances because it is a palliative treatment to help with symptoms. It can also be used in conjunction with curative treatment model. If you have a patient that's got a huge lung mass and they have increased pain and dyspnea, they're doing chemo, but the tumor is too big to do surgery. Palliative radiation is going to shrink that tumor down and it's going to help with the pain and the dyspnea, but it's also going to help to maybe shrink it down enough for a surgical intervention. So that's kind of how it's used with curative treatment. There's a chart in your book, or a table, 7.2, that does a side-by-side comparison of palliative care and hospice. So with hospice, the patient has a prognosis of 6 months or less. Now, do we think they've read the textbook and they're going to follow that trajectory? Not necessarily. But what that doctor is stating is that should the disease run its typical course, it is expected that the patient would die within 6 months. With palliative care, the patient can receive that at any time, in any stage of a serious illness. In hospice care, when you provide care, you cannot have any curative treatment, such as chemo, for your terminal diagnosis. So if you're admitted to hospice for cancer, you can't do curative chemo or curative radiation. You can do palliative radiation, but not curative. And I'll get into curative treatments for other issues a little bit later. But for the most part, no curative treatments. With palliative care, a consult is provided that is concurrent with curative therapies or therapies that prolong life. But again, they can also be congruent with hospice. With hospice care, the patient is admitted for a 90-day period of time, and then they're recertified every 60 days to make sure that they're still appropriate. With palliative care, care is not limited by specific time periods. With hospice care, you have ongoing care that's provided by RNs, social workers, chaplains, and volunteers, also a medical director and home health aides, if it's done in the home. With palliative care, they see their primary health care provider and they make recommendations and referrals and maybe following up with that patient. Misconceptions of hospice, and let me tell you, there are many. You have 6 months to die or you're discharged. No, that's not the case. As a hospice nurse, you do have to be able to chart that your patient is declining, whether it's physically or cognitively, that they are declining and becoming closer to death. I have had hospice patients for a year No treatments whatsoever, palliative or curative. Well, we've already talked about palliative, and we know that while they're not always common, we can use them with hospice. But what about curative? Can we do any curative treatments on a hospice patient? Actually, you can. So let's say that we have a patient, again, for cancer, and they develop a UTI. That's an acute affection. If we don't treat it, they're going to get uroseptic. Are they going to die faster or slower than their prognosis? They're going to die faster. So again, we're not trying to make them die faster. And is it going to have any impact on their terminal diagnosis? Are they going to live longer because we treat that UTI? No, it's not going to affect their cancer. They're still going to be on the same trajectory. We take away all of your meds and we only give you hospice meds. I have heard that so many times. That is not the case. Hospice does do a thorough medication evaluation at start of care. The reason that we do that, let's use the example of dementia. Medications like Aricept and Namenda, I'm sorry, I forgot to look up the generic name, I'm a horrible person. Anti-dementia medications, they only work to a certain stage of dementia, right? And usually by the time hospice is seeing them, they have far surpassed that stage. So they're no longer beneficial, they're not doing the job they're intended for, and they're causing side effects. But man, do these families want to fight about it because they say it helps control behaviors. So you have to educate the family and the patient. There are other medications that can treat the behaviors more effectively with fewer side effects. And that's what hospice does with all of the medications that a patient is on at start of care. Only certain diagnoses will qualify you. No, I'll admit that cancer is easy. That's an easy admission. You really don't have to back that up with a whole lot of documentation. They've got cancer, easy admission. Dementia is a little bit harder because, again, they have to be at a certain stage in their disease process. And certain types of dementia progress more quickly than others. So if I have a patient that's got vascular dementia, which is more rapidly progressing, I'm going to have a pretty easy time admitting them to hospice. But what about a patient with Alzheimer's, which can last 12, 14 years? That's a little bit harder. We have to be proving that they are at this stage in their disease process. What about when you don't have a clear-cut diagnosis at all? Maybe the patient's got CHF, but their ejection fracture isn't low enough to qualify them for hospice. But wait, they have decreased mobility because of that. They keep getting pressure ulcers. The pressure ulcers keep getting infected, and they're also at risk for DVT. So when you combine all of those things, and those are hard admissions, but when you combine all of the factors, the comorbidities, then you may have a hospice appropriate patient. All right, my dementia patients. Your family has to fight with you to get you to eat. You're very rarely remember any of your family members and are mostly incontinent. One of your friends or family members gets too upset seeing you like this and they don't come around anymore. Please pick one of your people, read it quietly to yourself, and then discard it by your desk because they're no longer coming to visit you. Lung cancer patients. Your O2 is now 4 liters per minute nasal cannula, which is causing irritation to your nose and throat. The medications are causing some nausea, and you don't feel well enough to leave home. One of your friends and family members struggles to see you like this, and they don't come around much anymore. Please select one of your people cards and discard it. All right, everybody. Let's take a quick 10-minute break. and we will come back. Dr. Anderson?
She.
Oh, she left.
Are you trying to turn it down?
Or I'm trying to turn it up.
Like more air or?
Yeah, I'll keep fan higher. Thank you. I can't wear my glasses with a mask, so I'm struggling to read.
Like this.
Yeah, that'd be great. Thank you. I'm a hot-natured person anyway, and getting up when you're nervous, and people are like,
I don't like to stop smiling anything.
I bought them. And I wanted to, she's like, I would just like my sister. It's teaching me like. I was so done. And then she was like, oh. Are you just gonna, yes, all right. That's perfect, these masks are great. You can
It makes me turn red. Stop talking about it. Oh, you guys are so quiet this morning. It's Monday.
It's Monday.
Sorry. They were terrible.
Oh,
no,
they're
not that. Terrible. They're not terrible.
I did.
What do you mean by not terrible?
I mean,
Like we have Kristen, I said, I'll put
okay,
this.
so what do you have to have to get anything else covered? Hey,
Okay, is everybody back?
everything's fine. They're good. They're not bad.
She's like, you're not good, they're not bad.
I haven't done an analysis or anything because the world was just falling apart over there.
We're gonna make y'all deep breathe for another 30 seconds.
I screwed up all of the stuff on Blackboard Canvas. I'm not even on the right part. It's fine. It's same difference. So it's fine. Are you singing? Come on up. Serenade us. Okay.
All right. Does anyone have any questions so far? We'll let Dr. Adams have a few seconds to get to back to her office. Okay, what's your question?
Have you ever had someone be on hospice and then decide that they want to like pursue curative treatment?
Yes.
And like switch?
Mm-hmm. Yeah, that's what they do in that situation, and I'll talk about it a little bit more later, but is what they do is they revoke hospice. You know, we don't keep people against their will. If they decide 2 months in, you know what, I'm ready to fight again, yes, they can revoke hospice and seek curative treatment models.
Hey guys, listen up.
Anybody else? Yes.
So, there's like hospice, and then you like, I think Bruce and Blair's are almost standard, kind of like, I guess like a hospital, kind of like that, but then you also have like Scotland, they go to your house.
Yes, and that's actually going to be your most common type of hospice, because a hospice house is for a maximum of 2 weeks. So unless your family member is in a hospital and they are declining very rapidly, and they think it's only going to be 2 weeks before your loved one passes away, then they may a hospice house. But they don't keep patients long term. They also can give caregiver respite. Like if the caregiver has their own physical issues and they need a break, you know, they will keep the patient for a period of time to give that caregiver some time to get back on their feet. But for the most part, these home hospice agencies, and in this area, we've got Caris, Avalon, Amedisys does some home hospice, Mountain State, and Ballad. So we have a lot of hospice options in this area, and I always encourage the patients to interview with the various ones to make sure they were getting the best fit, because you only get one shot at having the death that you want. So, but you can also go to people's homes, but you can also go to long-term care facilities or assisted living. So I had many patients at like NHC, Grace up in Abingdon. So lots of different settings for hospice. Yes, sir.
Where does like comfort care, like in the hospital, fall? Like, is that considered hospice?
I did have palliative care in the Black patients on 2 West, which is the oncology palliative care. We tended to try to get this set up with either a hospice house, which I've worked in when I worked for Ballad and I absolutely love it. It's a great place. Or if they're going to have a more extended prognosis, then we're going to try to get them set up with one of the outpatient hospices. But there were a few that we were looking at a matter of hours or a day or two, especially if that family member had become attached to the nursing staff on 2 West because they've been with us from the very beginning, then we would go ahead and do the end of life care on the floor. So it really just varies from situation to situation.
I had about like 4 or 5 patients this summer that I did like in the life care because she considered it comfort care.
Mhm.
She gave them morphine and just kept them comfortable and clean and just eat them out and they did that's what they
So usually if you're doing that in a hospital or a hospice house, we're not looking at months, looking at days. Anybody else? Okay. So the really neat thing about hospice is you have an interdisciplinary team that helps to meet the needs of the patient and the family. Because when you're working hospice, you don't just have a patient, you have an entire family that you provide support and education to. A chaplain is one of the members of the team, and they make sure that the spiritual and religious needs are being met. The nurse does the assessments, start of care, recertifications, and it does have to be an RN that does those type of visits. An LPN can do just a basic routine visit, but the RN has to do the admission and the reassessments. So she's going to be assessing those medications, assessing for symptoms that aren't being controlled or not being controlled well enough. And she's going to do a lot of education. Education with hospice starts at admission, and it continues on. The medical director, now the medical director may manage the medications and the treatment if the primary care physician opts not to. A lot of the primary care physicians in this area know that these hospice medical directors, they know their stuff. They know it better than them. So they'll say, you know what, let Dr. Shrinker manage the medications and the treatments, and y'all just keep me up to date. And you do need to be updating that PCP and keeping them involved in that care. The social worker can help with getting advanced directives in place. You would be surprised how many hospice patients come on board without a DNR. So they're going to help them with that. They can also help them look for services if they need like a part-time caregiver to help with the primary caregiver.
Do you have to be DNR?
I'm sorry, what?
Do you have to be DNR?
That's going to vary from company to company. Caris did not make you sign a DNR at start of care, but visit 1, the social worker started educating them. And they were very clear that we will not code a patient. I can tell you as a nurse, I had a problem with that because I am qualified to resuscitate someone, and if they do not have a DNR, I feel that legally I need to attempt resuscitation. But my company policy was, even if they don't have a DNR, you do not. Luckily, it never came up because I probably would have been coded.
They're like legal.
Oh, I know. Mhm. There was some kind of stipulation. I did make them show me the stipulation, but I still felt in order to protect my license, I can get another job, but I can't get another license. And that needs to be your mindset with any job.
Did like the patient sign something whenever they, sign on what?
Yeah, they signed that they understood that we would not code. So that was part of, yeah, it was part of the loophole. Volunteers. Okay, volunteers can't do anything clinical. They can't even so much as hand the patient a Band-Aid or a Tylenol. But let's say the caregiver just needs to run to the grocery store for about 30 minutes to pick up some groceries. You know, they can sit with the patient so long as they don't have to do anything clinical. They can also just go and visit with the patient and the family to help them feel supported. The health aides, man, they love the health aides. I swear they love the health aides more than the nurses. Because those health aides, they give those patients a bath. So that caregiver's got the day off to go sit on the couch while the health aide is giving the patient a bath. Now this next slide is going to be the bane of my existence. Dr. Edmondson told me, and I did not know this, that you have to use the generic name for medications because that's how NCLEX tests you. I am going to give you both. I am going to give you both names because you're probably going to be hearing some of the brand names. So symptom management is the primary focus in hospice, and there's 5 symptoms that we concentrate on controlling: pain, dyspnea, anxiety, nausea, and constipation. So with pain, our gold standard for actively dying patients, now we don't start this day one, but when they're actively dying, is liquid morphine sulfate, which is called Roxanol. And the reason we use that is that towards the end of life, when the patient is actively dying, they may be decreased level of consciousness and unable to swallow pills. So you can administer the liquid morphine sublingually under the tongue, even if the patient cannot swallow. Hydromorphone, also called Dilaudid PCAs. I have seen this used on a couple of cases, but not very frequently. Now, when the patient is able to swallow, when we're earlier in the hospice care for these patients, oxycodone and methadone, I've seen them used. I have seen fentanyl transdermal patches used, but not so frequently because there's a lot of variables that can affect the absorption and the metabolism of the fentanyl patches, and one of them is subcutaneous fat, and a lot of these patients don't have a lot of subcutaneous fat. So I've actually only seen this on 1 or 2 patients. It's not very common. For dyspnea, you can use supplemental O2, atropine, and that's in the form, it's the eye drops, the liquid eye drops. Because again, when it comes to actively dying, these patients may not be able to swallow, and you want to be able to control their symptoms. So you give the atropine sublingually. Hyoscamine, also known as Levsin, is another medication that we use for dyspnea. Now, if you notice, and also lorazepam, also called Ativan. If you notice, do you think any of these meds are actually for breathing? No, they're off formulary use, okay? They have just proven to be effective because atropine and hyoscamine are anticholinergic. So what do? They dry stuff up, right? So you're going to see that a lot with end-of-life care and also with cancer patients, that you're using a medication that's not really what that's for. Anxiety. Our gold standard is lorazepam. And let me show you why. What do you see here? Lorazepam, lorazepam, lorazepam. Why do it with 3 meds when you can do it with 1? You want more bang for your buck. So that's why we normally go to lorazepam as the primary anxiety medication, because it helps with other symptoms as well. Diazepam or Valium is another backup medication that you can use for anxiety. Nausea, okay. Promethazine, also called Phenergan. An oldie but a goodie. It's very effective for nausea. Prochlorperazine malate, also called Compazine, is effective for nausea as well. Lorazepam, metoclopramide, which is Reglan, which normally is used for the GI symptoms associated with like IBS. Haloperidol, Haldol, diphenhydramine. And again, with the diphenhydramine, it's that same concept of drying up the secretions, but it helps with the nausea as well. Constipation, you may be thinking, that's a weird symptom to just be throwing in there. But what do all of these medicines up here do, these opioids? What are they notorious for? Constipation. What do you think these anticholinergics are going to cause? Constipation, yes. So I am a firm believer that an ounce of prevention is worth a pound of treatment. If you can prevent it, that is way, way better. So we're going to be prescribing medications to help these patients to not get constipated, because disimpaction and enemas are fun for no one.
So
Yes.
if someone like had asthma and they had albuterol, would they be able to use that inhaler?
Yes. Yeah, absolutely. Okay, dementia patients, you don't want to eat at all, and you're completely incontinent. You're combative at times, and you recognize no one, and are completely dependent on others for care. Please give up your last food card. Lung cancer patients, your dyspnea and pain have confined you to bed. You have no appetite, but you do have breakthrough medications for nausea and pain. Please give up your last food card. Pain management goals and focus. Again, I told you all before that hospice is different than any other specialty in nursing. Do we need to worry about in our hospice patients? No, they're going to be on those meds for the rest of their life. Respiratory drive, if the patient is actively dying. Now let me be very, very clear. There is a big difference between a hospice patient and an actively dying hospice patient. An actively dying patient, you are looking at seconds, minutes, maybe hours. But this patient is on their way out of the world. So if your patient is actively dying, we are not going to be overly concerned about knocking out their respiratory drive. But to be clear, you would never purposefully do it. The FLAC score, have y'all heard of the FLAC score? Okay. So originally the FLAC pain assessment was created for babies and small children. And it's face, legs, activity, crying, and consolability. But like with a lot of things in healthcare, it was created for one thing, but it's beneficial for other things. A lot of ICU nurses, I've used it in the ER, and hospice nurses use that pain assessment very frequently. Because if for whatever reason your patient cannot communicate to you, that is how you tell if they're experiencing pain. Because just because they appear to be obtunded or comatose, do you think that they cannot experience pain? No, they can. So you're going to be watching for tension or guarding, for grimacing. Restlessness and anxiety can definitely be a symptom of pain. The majority of the time, and this is why the PCPs tend to defer to the medical directors for the hospice medications at least. your medical director is going to give you an order for 1 milligram of liquid morphine every 5 minutes, so long as you can chart nonverbal cues of pain. That can slow their breathing, but that's not your priority at that moment. Your priority is keeping them comfortable because they are imminently dying. Safe dosage practices. So with a lot of these medications for pain, you have parameters that say a patient shouldn't take between this, any more than this amount of medication in a 24-hour period of time. Do you think that's the case with hospice patients and or cancer patients? No. These patients build up tolerance. Okay, when you have to take something as often as they do, you're going to get tolerant to it. You may start within the safe parameters, but you're probably going to end up outside of them at some point in care. I had cancer patients that took enough hydromorphone to kill an elephant, and they were walkie-talkie. I'd be dead, but they were fine. Barriers to care. I'm sure that you all have heard of the stages of grief. Usually we apply that to the loss of a loved one. But can you apply it to a terminal diagnosis? Do you think you're going to feel grief if they tell you you've got stage 4 lung cancer? I'm guessing you probably are. So denial and isolation are the first stage. Anger is the second. Bargaining is the third. Depression is the fourth. And finally, we end up at acceptance. Do patients go through it in order? Not always. But if you get a hospice consult and the patient is at this stage, anger, how well do you think that consult's going to go? It's not going to go very well. So patient readiness can be a big barrier to providing hospice care. They can be a textbook hospice appropriate patient on paper, but until they are ready, they are not hospice appropriate. Family readiness. Oh man, this kills me. I have watched family put their loved ones through hell, and the poor patient does not want to tell them no. They're tired. They're facing their 3rd round of chemo because it's come back twice. But they don't have the heart to tell their kids, I'm done, I'm tired. The most tragic thing for me is to watch a patient who has known for months that they're not going to make it, but they go through hell for their family members. And they die in a hospital fighting. The culture. All right, we're in Northeast Tennessee, Southwest Virginia area. Can you say someone died? No. What do we say instead of a patient died? Huh? Someone say they passed? They passed. They went to a better place. They went to Jesus. And on. You know, we can say 10 different things other than the patient died, and it's acceptable in this area. But you have to say the patient died. He has died. Now you can follow that up with a compassionate and comforting statement that's in line with their religious beliefs. If I'm tending to a Christian family, I'm going to say, he has died, but he has gone home. You know, something that's in line with their beliefs. But you do need to say it, because I have been in the room when the resident has said to a friend, they've gone to a better place. God love this family member. They said, Johnson City Medical Center. It's not a good conversation to observe. So you have to be clear. And in this culture, a lot of times that's very uncomfortable. It does get easier. And then again, some of the misconceptions that we talked about previously, those can definitely be a barrier to care. You know, if they hear all these horrible things about hospice, do you think they're going to be ready to sign up? They're going to have a pen in their hand when you show up? No. And that's why education is so important. I always ask them when I went to go do an interview for an admission, I'm like, well, tell me what you've heard about hospice, just like I did with you all with the discussion board. What have you heard about hospice? What do you know about hospice? And that way, if they had one of those misconceptions, I could educate them. Cultural and religious considerations. So with your Jewish patients, a lot of times they're going to have conflicting views with end-of-life care because it threatens their maintaining of perfect faith that God will heal. A lot of times with your Jewish patients, you will see them do whatever possible to extend life. I have an aunt and uncle in Birmingham that are of the Jewish faith. I mean, he was even in a Holocaust. I was quite frankly surprised when I found out my aunt was on hospice. I was very happy, but I was surprised because for the past 2 to 3 years, they have taken extraordinary measures. The Muslim faith. The care tends to involve not only the immediate family, but the extended family as well. And only the same sex can be present when intimate areas are exposed. So if you're having to do incontinence care, it needs to be the same sex person doing it. Sometimes they view pain as a trial from God, and so they have some complicated views on pain control. Sometimes it's okay, sometimes it's not. So what I always say, when in doubt, clarify. Almost always, with any of your patients that you encounter in any of your specialty, what's one of the questions you're going to ask them? Do you have any religious or cultural beliefs that affect how we take care of you? And if they do, you need to be documenting them. That way you know. You know, like Jehovah's Witnesses, they don't take blood products. Nor do they celebrate birthdays. That's a big one in home health. You don't want to walk in and say Merry Christmas or Happy Birthday. That wouldn't be appropriate with them. Buddhists. Buddhists believe that you must be as alert as possible at the time of death. So they may refuse pain control, number one, to stay more alert at the time of their death, but also because they believe suffering and pain is a part of life. The Hindu faith, they believe that it's the family's responsibility to care for the dying. So if you were the RN, you probably wouldn't be doing incontinence care. The family would be doing it. They want to do as much as possible for that patient. And they have a lot of rituals for death and dying. Physical signs and symptoms of approaching death. This is a big one that you need to be teaching the patient and the family about. I'm going to use an analogy for this to kind of explain some of this. So if we're in the middle of a natural disaster, like in New Orleans when Katrina hit, and the power goes out, and you're on a backup generator, I want you to think about that. So we're on a backup generator, we are not full power. Cool and mottled extremities. Have you ever gone outside and you get really cold and your skin turns pale and you see like this purple marbling? That's mottling. You can tell the family members that they can cover the patient with a blanket, but what is happening is the body is shunting the blood to the trunk so that it can keep the brain and the heart going. It's not worried about the extremities at that point. It's in backup generator mode. It's just trying to keep the body going. Increased sleep. This ties into the next symptom, but the intervention that they can do is to sit quietly with the patient, hold their hand. They can talk softly to them, even if the patient can't respond. Decreased appetite and thirst. This is a huge one in this area. Going back to the culture of this area, what are you always supposed to do? If you're sick, you what? Eat. If you're happy, you eat. If you're sad, you eat. That's Northeast Tennessee, Southwest Virginia. Food is comfort. So these family members do not take it well when their loved one stops eating and drinking. I have lost count of how many times I've had to talk family members off a ledge. It's like, no, we're not going to start IV fluids. We're certainly not going to do tube feeding, because is the body capable of taking in nutrition, digesting it, and doing anything with it when it's in survival mode? When we're on the backup generator, are we worried about eating and drinking? No, we're not. So what's going to happen if we force fluids and food down a patient who can't handle it? We're going to vomit. We might aspirate. Horrible diarrhea. Bad things are going to happen. But what can we let the families do? Mouth care, definitely mouth care, ice chips, and chapstick. Those are things that'll help the family stay busy and to feel good that they're doing something for their family member. Incontinence, clean them up and dry them. Now again, this is the only specialty in healthcare where you can get a Foley catheter order for the patient's comfort or for caregiver relief. If you're in the hospital, you will not get a catheter for comfort. Death rattle. This is the single most distressing symptom for the family. And it can be for the nurse, okay? It's not pleasant. It sounds like the patient is drowning from the inside out. You can elevate the head of the bed. You can give the atropine. You still may not be able to get it controlled. I've had a couple of cases where I have been leaning over the patient for an hour and a half, sweat dropping off my body, atropining them and roxanoling them, and I could not get the death rattles stopped. Now the patient was fine. Their FLAC score was a big fat 0, but that family was all to heck. So I had to say, come here. Look at her face. Look how peaceful she is. Look how calm she is. She's not feeling this. And that helped ease their anxiety. Changes in breathing pattern. Again, you can elevate the head of the bed. If they need supplemental O2, you can give it to them. That's not to increase their oxygen level, it's just to help with the dyspnea. And you can give the atropine. And lorazepam. Lorazepam is great for dyspnea. And you can have the family sit with the patient. And the changes in breathing pattern, again, they don't follow a textbook. You may just see a patient that their respirations just slowly start to slow down until they cease. But you also may see chain stokes or agonal breathing. Agonal breathing is not fun either because they gasp and it scares the crap out of you. I had a patient that didn't breathe for a minute and a half, and I went to go listen, and they gasped, and I was so not fun for anybody. Disorientation. Speaking softly to the patient, reassuring them, comforting them, and creating a calm environment is going to be big. You know, we don't need a lot of bright lights if your patient is disoriented and anxious. Okay, that's going to overstimulate them. So again, with like the restlessness and agitation, you're going to decrease that stimulus. Dim the lights. Provide a quiet environment. Is this the time to have 20 family members in the room? No. 2 at a time. Calm. And of course, you can give lorazepam for the anxiety. Hallucinations. There's really not a whole lot you can do about hallucinations except to educate the family that they may occur, that it is normal for them to occur, and to just sit with the patient and remain calm, hold their hand. You would be surprised how much just knowing what to expect alleviates that fear in the family members. All right, dementia patients. You have incoherent speech. refuse to eat, and become combative with attempts. Your family no longer recognizes you. Please give up your last card. Lung cancer patients. You are lethargic, can no longer tolerate food or fluid. You're completely bedridden and incontinent. Please give up your last card. Pronouncing the patient dead. The laws are going to vary from state to state, but in Tennessee and Virginia, an RN can pronounce a patient dead. But you have to listen apically for heart sounds and lung sounds and palpate a carotid pulse for 2 full minutes. And all 3 have to be absent, and then you can call time of death. Postmortem care. Yes.
The surest sign there. That you could say 100% is still that's
Yes. Yeah, there's one, yeah. Yeah, and probably there are people who are also going to be invalid. But legally, yeah, for Virginia and Tennessee, legally, those are the 3 things you have to
Now,
check.
does that vary, like, per hospital, like,
Per state,
okay.
yeah. So, I don't know what the laws are for Minnesota, but maybe not in Canada. So wherever you're practicing, you do need to know the laws regarding it.
So I think, they had a little bit, that they had to be 2 hours together.
But in the hospital, but like in a home health or a home hospice setting, I am not going to call that a nurse pronounce. So in that setting, one RN can pronounce, but they have to go through those steps. Yes.
So that's like a specifically a hospice nurse.
Yes.
Right, it's not like any.
Well, there's an exception to that. Like if they were at NHC, and if I was in Big Stone Gap, and they knew it was going to take me an hour and a half to 2 hours, then 2 of their RNs or the nursing supervisor could pronounce that patient until I could get there to do the other things that needed to be done. But for the most part, yes, the hospice RN is going to be the one that pronounces. 2 seconds. Okay. Postmortem care. I can't stress this enough. You're going to provide postmortem care with the utmost respect because you want to show that that patient was valued. You can invite family members to help clean the body if they want. Apart from suspicious circumstances that would warrant an autopsy, and yes, they can happen even on hospice, but if not, you're going to remove all tubes and lines. So Foley's, IVs, PICC lines, you're going to go ahead and take them out. You're going to close the patient's eyes unless it's contraindicated by their culture. And you're going to insert those dentures ASAP, okay? This is very important. You do not want to be the hospice nurse that hands the funeral home their dentures. I only did that one time, and they're like, great, we're going to have to break their jaw. Get the dentures in. You're going to bathe the patient and comb their hair to the family's preference. You're going to place a brief on the patient because you're going to have leaking fluids. You're going to dress the patient in the clothes that the family wants, not the funeral clothes, but the clothes that the family wants the patient transported in. I have had patients that I put fuzzy pajamas on them with their fuzzy blanket, and that's how the family wanted them to go. Whatever they want is fine. You're going to allow the family time to visit with the body before the funeral home arrives. You want to make sure that your paperwork is signed. And if you have controlled substances to waste, you need to do that with a witness. And yes, a family member can witness. You just tell them, this is the morphine, and you show them how to measure it so that they can understand what they're signing. Same thing with pills. You're going to provide emotional support to the family. And then you're going to notify the funeral home. Now, I put a star on this last one because this was just my company standard. We escorted our patients to the transport vehicle. We stayed with them to the very end until we transferred them to the funeral home. And this can be comforting to the family because a lot of times the family doesn't necessarily want the body going out without anybody, but it can be distressing for them to see their patient or to see their loved one being loaded into a hearse or a van. So you just tell them, I'm going to be with them. I'm going to walk with them. You can also review in your textbook chart 7.5. There are a few other postmortem care tips on there. Legal and ethical issues. Active euthanasia. Okay. I think of the Black Widow nurses when I think of this. This is when a healthcare provider actively does something to cause the death of the patient with or without their consent. An example of this would be lethal injection for the death penalty. That would be the only legal way that this could occur. I'm not going to get into ethics on that. But other than lethal injection, that is never okay. Physician-assisted suicide. Have y'all heard of Dr. Kevorkian? Y'all are young. Okay. Back in the 90s, there was a doctor, Dr. Kevorkian. I know, girl. I'm with you.
Y'all need to read up on it.
Yeah. So, in the 90s, Dr. Kevorkian assisted patients with suicide. And it was not legal at that time. In fact, there are only a few states that it is legal now. And it's a very strict process, because you can imagine this is a big deal. But in the states that it's legal, basically what the physician does is they give the patient the means to end their own life if a terminal diagnosis is present and confirmed. They instruct the patient how to do it. And these patients have to be alert and oriented times 4. They cannot be cognitively impaired in any way. Because the last question that they're going to be asked is, this will cause your death, are you sure that you want to do this? And they have to say their name, the year, they have to show that they are oriented, and they have to say yes. And then the patient takes it. The doctor does not give it to them. But a lot of states call that death with dignity.
So it's not considered suicide?
It is, but let me give you an example. Are y'all familiar with Huntington's disease? That is a horrible disease. Like, if they told me next year, you have Huntington's, you've got 5 years tops before you just lose your mind. And, you know, it's just not pretty. Also, certain kinds of cancers that they're going to lose their cognition and they know someone's going to have to be cleaning them up. That's not acceptable to some people. So technically, yes, it's suicide. And there's a lot of ethical dilemmas in the public view and also in the healthcare community. It's like those topics like abortion and the death penalty. You know, nobody is going to 100% agree as to whether or not it's ethical. But you have to look at if it's legal in that state. So, as a hospice nurse and some of the deaths that I've seen, I lean more towards, depending on the situation, it may not be unethical. It may be more humane.
What did they put on the death certificate? Do you know? Like, did it-
Physician-assisted suicide. Yeah. I mean, and I've never practiced in a state where it's legal, so I don't know if they put physician assisted suicide related to terminal diagnosis of, and whatever that terminal diagnosis they made. It's an interesting topic, you know, if you have nothing to do one night, you may want to Google it, but you're in nursing school, so that's not gonna happen for a while. Okay, withdrawal of care or withholding life-sustaining therapies was formerly known as passive euthanasia. This is basically, when you hear the saying, pulling the plug, or if your patient is the DNR, you're not going to intubate that patient because they don't want it. You're going to take the patient off the vent because it's in their advance directives or their power of attorney requests it. And you're going to allow a natural death to occur. The reason that this is different than active is because you're allowing the natural death to occur. You aren't doing anything to make the death happen. You are just withdrawing care so that it can happen naturally. Does that make sense? This is one of my favorite quotes that I think sums up hospice perfectly. You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but to live until you die. Thanks, Cicely Saunders. So I'm just going to give you a quick run through of what hospice care would look like for a patient. So the physician thinks that the patient has 6 months to live, and he makes a referral to hospice. The companies go out and they interview with the patient and the family to assess for readiness to see if they even want this. If they do want it and they're ready, then the RN will go out and admit the patient to hospice services, and they will initiate the interdisciplinary care team. Now, a patient can refuse any of the members within that interdisciplinary care team. I have taken care of atheist patients that have refused the chaplain. I've had patients that have all their ducks in a row and they refuse the social worker, and that's fine. They can customize which members they want involved in their care. So the patient gets admitted for 90 days, and the RN goes and recertifies the patient. If we can show that that patient has declined, we can recertify them for another 60 days. There are only 3 ways out of hospice. Revocation, like what we were talking about, the patient no longer wants it. They want to revoke hospice. They sign a form and they revoke hospice. Discharge. Discharge is going to occur if your patient is not showing decline. If they reach what they call extended prognosis, basically they're just not following the textbook. They, for some reason, kind of gone into this weird kind of chronic phase, but you can pick them back up when they start declining again. And obviously, ideally, we want our patient to die a good death, and we want to support the family through that process. We already talked about hospice house a little bit. I was just going to mention the difference, the 2 weeks, but we already covered that.
If they were like care, if they were like hospice care and then decide they want to go back into it, maybe reevaluate it and go back into it after they.
Yes, they can. I had a few situations, and this is where it comes into the family readiness, because a lot of times they'll take it, but they're not actually ready. And just like some of the games that are played in the ER, gravitate one to the ER, and come back and get readmitted. Was again, yeah. And we'll allow it a couple of times, but then, you know, we kind of have to say, we don't believe you're ready yet. Call us again when you are.
Because a lot of times it would be the family that would like push them to
Oh, yeah.
go to the ED, or they would call, and then they would get to the emergency department and we'd have like,
Night shift actually saw me a lot.
I called hospice a lot and I was like, I don't know what I'm supposed to be doing.
we come to the ER and they sign a revocation.
Yeah, I've seen them come in and have to talk to the patient, and sometimes they would discharge home instead of being treated, or they would sign and be treated.
It's a very big deal because what happens if, because like if I get a call and they're like, we're on our way to Bristol, I will meet you there, you can have no treatment until you sign that revocation form. Because if they don't, guess who pays for that ER visit, and God forbid that hospitalization? Hospice.
So that's something to think about if you're going to be working in like a clinic or an emergent care setting. Because that was something I didn't really fully understand until I was the nurse caring for the patient. And when they came in and they said, well, I'm on hospice care, I was like, okay, wait, what do I do about this? What can I do? And that type of thing. Because we have protocols in place that we can start an IV, that we can start like treatment protocols, but you don't want to do anything that could mess up their care with hospice. So just think about that before you like initiate like a protocol or something.
Because until that patient or family member, whichever scenario is more appropriate, signs that revocation, hospice is responsible for paying 100% of everything. That's why we don't go to specialists when we're on hospice. You don't need to see your oncologist anymore if you're on hospice. Or even OBGYN, you know, your care is at home. But if they want to sign the revocation, they can do what they want.
Is hospice on insurance?
It is, yes. Particularly with Medicare, that's why you have that standard of hospice pays for everything, because Medicare will give a lump sum payment to the hospice company. Out of that money, your meds are paid for, your treatments are paid for, and all of the interdisciplinary team is paid for with that lump sum of payment. So Medicare will make a lump sum payment to hospice for the first 90 days, and then the next 60 days. Any other questions? So how did y'all feel about the interactive activity? It's not a feel-good game, that's why I didn't call it a game. Did you feel like you had any control? Or did you feel a little bit powerless? Also, you know, here you are trying to pay attention to a lecture, and this interactive activity keeps popping up. I did that on purpose. Because if you think about it, these patients get these diagnoses, and then they go about trying to continue to live their life, and then these symptoms pop back up. And it's very hard on them. So the whole point of hospice is that you have an entire team of people that are trying to help you hold on to those cards as long as you possibly can. And that's why hospice is important. The company that I worked for had a sheet that we would give the patients and the families at start of care that was called the 3 most important things. And the patients and families would come up with 3 things that were very important to them to try to continue to experience for as long as possible. It could be knitting, it could be painting, it could be reading, it could be, I one that loved chocolate milkshakes, you know. It could be a lot of things. One of the first cases that I had as a nurse in hospice, they always, some of them stick with you more than others, but one of their 3 most important things was getting Christmas pictures taken so they could make Christmas cards. And my patient, he was so worried about that because he knew his wife was going to be so disappointed. So I decided I was going to go to their house. Believe it or not, I'm not a professional photographer, but now there were obviously pictures with their face, but I've chosen not to show them even though they signed a waiver. I took Christmas pictures in their home, and I made the Christmas card. You know, you get them on Shutterfly, you put all the pictures on them. And I gave it to him. She cried, he cried, I cried, everybody cried except the dog. It was a profound moment for me in my nursing career when I realized how much of an impact I could make for the patient and the family. So much so that they mentioned me by name in his obituary and thanked me for their service to them. There are moments in nursing that are going to change you, and you need to try to let it be for the better. I learned a lot from this patient and his family. But one of the most profound things that I've realized from being around that thing was that I was missing the love of a dog. So to this day, they still impact my life because I have my babies. And yes, sometimes I do still think about that patient and his family when I look at them. And so that's how they changed my life for the better, in a lot of other ways. So try to harness that, because there's a lot that you're going to see in nursing, but let it change you for the better. Does anybody have any questions? Oh, this is my little boy Digby, and this is his daughter Darcy.
Is that why you got that breed of dog?
I'm sorry, what?
Is the breed of dog the same type?
Yeah, they're white schnauzers, whereas Mac was salt and pepper, but I had actually grown up around schnauzers some, and I need a hypoallergenic dog, which they are, but they're also just ridiculously smart, and they have these huge personalities. And so being around their dog reminded me how much I loved that breed, but I had never really been ready to commit, because Dr. Edmondson will tell you I commit to my animals probably a little bit too much. He has seizures. He has been to the University of Tennessee. Yeah, I'm that dog mom. But he's only 4 years old, so I'm not ready to let him go yet. But they're great dogs. Any other questions?
I have a question. I'm just curious because the day when I was doing my clinical in the hospital,
Mhm.
I noticed that there was a patient who was retaining, urinary retention.
Yes.
So she was increasing, I think, what, like 12 hours or so.
Mhm.
So what I noticed is that they call to the EMS to take the patient to the emergency room and the hospital to do the catheter and release that. So I was wondering if they are, as a hospice nurses, they don't let it go to do that or.
And this is a hospice house?
Yeah. So I didn't ask that one, but I was wondering because then later after the patient come back,
Yeah.
that it was something that fully got it. So I don't know.
I know that she was asking, she was doing a clinical at hospice house, and the patient had urinary retention, and they had to transport him to the ER to have a Foley catheter put in. I know that when I got pulled to the hospice house, they had a hard time keeping RNs, and I can't remember what their policy was on that. The only reason that I would think of that they would transfer the patient is if one of the nurses there did not know how to do it. I'm not
Yeah,
sure.
that was it was it was a mistake that don't ask. I should have asked why they were taking it, but yeah. I didn't ask because I assumed it was something about the police or something like that, but I wasn't 100% sure.
Well, and it may be like, we talked about company policies, like with Caris, where I wasn't supposed to code a patient if they didn't have, even if they didn't have a DNR. Companies have policies and protocols. So anytime you're working for one, you need to know what they are, because something may be in your scope of practice, but the company that you work for may not allow it. So, always be aware of those things. But specifically with that, I'm not sure. I'm sorry. I wish I knew. Anybody else? Okay. So what I would like you to do, and again, I'm not worried about grammar or length or, you need to have good grammar, but you don't need to have cites, and you don't have to have paragraphs and all that stuff. But go back and respond to your own discussion board. Maybe tell me if any of your emotions have changed towards hospice, your your perceptions have changed a little bit, and maybe one or two things that you learned today. Hopefully you learned something.
And then there's an evaluation.
Yeah.
Have you guys fill out. So you'll give that to me, so that, or whatever you do. But I do need it back. Do you want your little cards back?
No. Papers everywhere.
Can you guys thank Ms. Taylor? She's put a lot of work into this.
I like the activity. Cool.
Yeah.
Very.
No, I really think I want to participate, because I know how this is going to
So I had my mom as the mouse part.
It's hard, even when it's like it's hard.
It's like she literally leaves. Well, my mom
Thank you.
Yeah, I don't know a lot, but
And most diagnoses are like hard for me, because my mom has dementia and my grandmother has problems.
so I was like, oh.
Yeah. One of my best friends, she's diagnosed substantial. And so
What's the whole outlook?
I'm just coming next to that. Good job.
Oh, sorry. I'm just over here loving that I get to sit in the lecture and not stand up here and talk.